Just wanted to say welcome everyone to this evening's YANA program. This week, we're doing it on the impact of COVID-19 in New England. Topic is healthcare providers' perspective. It's been arranged by the New England chapter of YANA. We've got some of the leaders in our panel right now. Before I turn the program over to Joellyn Gray, Joellyn, you want to wave? I don't know if everybody can see. There's Joellyn. And Michael Kurs has got a picture in the bottom of your screen if you have the same panelist view that I do. They'll be leading the program, but we wanted to start with one of our panelists who's they're all taking time out of their busy days, but Steve Bird actually is in between shifts, so we promised we would get him online first and so he could get back to work. I'll just give a quick introduction. Steve is a fellow classmate from Yale, class of 1991. He's a professor of emergency medicine and clinician at the UMass Memorial Medical Center in Worcester, Mass. He's working nights in the emergency department. He's head of the emergency department. He's growing capacity for the wellness of not only other doctors and interns, but most of the staff there. So Steve, I just wanted to say, welcome. Thank you for coming in. Just wanted to start with a couple of quick questions, like what's it like there in the Worcester emergency department, the ICU, and what do things look like from your perspective?
Yeah, thanks for having me. It's been interesting, to say the least. We've really learned a lot over the last 4 weeks. Up until about a week ago, our overall volume in the hospital and the ER was down significantly. At one point, we were about 25% of our normal patient volume. I think people were staying away, and all of the volume that we saw was COVID or presumed COVID positive patients. But in the last week, things have really escalated. We are in the surge, as Governor Baker said now. Our volume is back almost to our pre-COVID amount, and much of that are COVID-related illnesses. Our ICU at UMass are now full. We have about 175 ICU beds currently. We have excess ventilators, fortunately. We've created new ICUs throughout the hospital. So the post-anesthesia care unit, the interventional radiology unit has become new ICUs. And the usual ICUs have all been retrofitted with negative pressure. So all of those rooms in the traditional ICUs now house COVID positive patients, and they're all full.
And Steve, what do you expect to be happening over the next couple of weeks?
Unfortunately, I think we are at the beginning of the surge in Massachusetts. So things are going to get worse before they get better. The hospital, we were very fortunate, and in 8 days, we created a DPH licensed hospital in our civic arena in Worcester. So in 8 days, we went from 50,000 square feet empty space to a 220 bed licensed hospital, complete with an ICU, complete with redundant electrical supply and medical grade oxygen pumped to all 220 bays in the Civic Center. We graduated our medical students early at UMass, and most of them have agreed to sign on. They got expedited licenses by the Board of Registration of Medicine in Massachusetts, and now they are working in our COVID units. So it's been remarkable. We had about 1,000 people volunteer to work in the COVID units, retirees, people who were just out of the workforce, including the medical students.
Wow, that's amazing. And what about supplies? Does everyone have what they need?
Yes, I don't feel it's an issue where we are. We are reusing N95 or KN95 masks. We are currently using a UV decontamination method at University of Nebraska, where there is an Ebola unit there. So we learned from them. So we're using masks 4 times. After 4 times, you get a new one. All the other PPE, we seem to have enough, and we are not being asked to reuse anything else. It's all single use. And so I think we're doing okay. Now, what will it be like 14 days from now? I don't know, but currently we're doing all right.
That's good to hear. That's really good to hear.
Steve, I wanted to ask, I know you've been at the forefront of some of the opioid crisis, including research and novel treatments. Is any of that helped you be able to prepare and approach what you're going through right now?
Yeah, so we've been doing a lot of telemedicine for substance use disorders. So prescribing buprenorphine with telemedicine consultation of patients. And so I think that postured us for a bit of easier transition to general telemedicine outside of the opioid realm. And now, virtually all of medicine is conducted via I'm exaggerating, but much of medicine is being conducted via telemedicine. And it's interesting because in the past, doc said, no, we need to see the patient needs to be here. Patients like that interaction with their physician. But when that's not happening, and it won't be happening for a period of at least a few months, right? What does the new normal look like for much of medical care? And maybe telemedicine, obviously it comes down to, is it reimbursed appropriately? But if it is, maybe this is ushering in a bit more of a telemedicine way of doing things in the United States.
Interesting. Interesting to hear from the other physicians and healthcare providers, whether that's a change that may have some lasting impact. And I think one of the last questions was, do you think anything you're doing now, going through learning with this crisis with your colleagues, is going to maybe be implemented in new protocols going forward?
Yeah, I've been thinking about that. Certainly what usually takes months to do in an academic medical center health system, we are now doing in days or hours. I suspect that's hard to maintain.
Mm-hmm.
But the other interesting thing is we are often looking at expanding services, expanding this, doing more of things for patients and patient care. But what we've really done in the last 4 weeks is pare down to the essentials. So it's really a different way of working. I think we are trying to do things in a patient-centered way, but when people are dying alone, they are not able to have any visitors in the hospital or in the ER. It doesn't seem very patient-centered. So that's one thing I hope we get away from when this is over.
Great.
That's great.
If there's anybody on, any of our attendees or online who have questions for Dr. Bird before he leaves, I think someone had a question. Oh, Toddy Turrentine. I don't know how I can, what do you do if someone raises a hand? I think I can let her. Toddy, I'm going to let you talk, okay? Hang on a second. Toddy?
Yeah, I have a very granular question. We are lucky enough to have some N95s, and I felt guilty about having them and offered them to our local EMS, and they say they're well supplied. But anyway, I wanted to know whether spraying them with alcohol, isopropyl alcohol, disinfects them.
Yeah, that's a good question. So the two major ways that N95s are currently being disinfected, if you will, are by UV radiation or by hydrogen peroxide sprays, if you will. So the Battelle Corporation has now 4 active units, I think, in the United States. We have one in Massachusetts where they can recycle 80,000 masks a day. So alcohol, it will work, but I think there is a lot of concern about the degradation of the mask contents by alcohol. So it's generally not recommended.
Okay.
Thank you. I know, Steve, that you're working tonight, and you promised us 3 minutes. You've given us about 5 or 6, so thank you so much for doubling the time. And we're sorry that we're cutting into your sleep time before you take your shift.
Yeah, no worries. Thank you for the opportunity. I really appreciate it.
Thank
Well,
you,
thank you
Steve.
for being on the front
Stay
line.
in touch.
That's
and
amazing.
Be healthy and safe.
Thank you. Everyone be well. Good night.
Same to you. I'm Joellyn Gray.
Go ahead.
And I'm a member of the New England leadership team. And there are 2 other members here on the screen, Michael Kurs and Robin Noble. And I wanted to give you just a little bit of a background, all of you, as to why we're doing this event tonight. We had our weekly or monthly call 2 weeks ago and casually said, hey, Robin, how's it going in Maine? And we were stunned by her response. I don't think any of us had a view into what life is like on the front lines. and for anyone in the medical profession through all of this. We all live in our own kind of world. And instantly we said, we need to share this. This is incredibly important. All of you in the healthcare profession are so important to us, and we don't understand all of the stresses that you're going through and all of the ways in which we can help you and all of the issues that really all of society needs to grapple with. So we have assembled this event tonight. It includes professionals who are both doctors on the front lines in emergency medicine and infectious diseases. It includes doctors whose expertise is different, but who are being asked to work in a new area to help in this situation. And it also includes others who really touch on related aspects of COVID-19, things like mental health and ethical decision-making. So I want to say thank you, first of all, to all of our panelists. We really appreciate the time that you're taking out of your day to help us. And I also wanted to introduce you to Michael Kurs, who is going to be the moderator for this evening. Michael is a member of the class of '77. He is an attorney at Pullman and Comley, and he has decades of experience in working in healthcare law. Each presenter will speak for roughly 5 to 7 minutes, and then we will open it up to questions. Please use the chat box down below so that we can record your questions. And I should also mention that this event is being recorded and will be available on the YANA website within a few days. So Michael, why don't you kick us off by helping us understand what's going on with COVID-19 in New England? Put us in context.
Let me do that. If it's because Steve Bird triaged my problem, my Zoom audio before he took off. So let me start with this. Joellyn passed along a news report this morning that says 9,200 healthcare workers have been infected with COVID-19 nationally. That CNN, who reported that, says that's likely an underestimate. The New Haven Coliseum, which opened in 1972 and fell to the wrecking ball in 2007, had a capacity of 11,171 people. So you can imagine the numbers of infected healthcare workers are going to run past that capacity soon. And you could have filled the old New Haven Coliseum, where some of you way back when went to hear rock and roll, with the number of people who are on the front lines of the healthcare efforts and who are affected. Here's another number. The Hartford Current of April 3rd reported 51,000 people had died in the United States from the virus. And that number exceeds the capacity of Fenway Park in Boston, which is 37,400, and the number is likely to approach the 57,354 person capacity of Shea Stadium, where the New York baseball Mets played for many years. I know that because Dr. Anthony Fauci predicted 60,000 US deaths by early August. That number, when I first heard it, struck me as eerily similar to the 58,000 plus fatalities for United States military forces in the Vietnam territories during the Vietnam War. There are numbers reported daily in New England state that we can about. Yesterday's numbers for COVID-19 associated deaths in Connecticut was 868. Connecticut's said to have had 612 U.S. military fatalities from what was also called the Vietnam conflict. His count as of yesterday was 1,108 deaths associated with COVID-19. Its U.S. military Vietnam War casualties numbered 1,131. I'll give numbers from other states, though I'm not sure what the numbers really mean for most, other than we ought to take the safety precautions that we can to keep the numbers from growing from this pandemic and the next one. The numbers don't really mean too much to anyone who has a loved one or a friend or a colleague who has been infected and worse, who have died. It's that personal experience, which is most important to them. The aggregate numbers probably mean so much less. Rhode Island's fatalities as of yesterday were 87, Vermont's 30, Maine's 24, New Hampshire's 32. I'll also mention New York. On April 10th, the BBC reported New York to have a COVID-19 caseload, infections of 159,000 plus, more than any single country outside the United States. Today, New York State's death count is being given as 12,192. Its Vietnam War fatalities numbered 4,119 in the state. Let me say that I hope we have a chance tonight to talk about COVID-19 ethical questions, questions about race, age, economic status, poverty, about what's happening in the prisons and other institutional settings like nursing homes, how the hospitalized confront COVID-19 and how their families confront COVID-19 when they have hospitalized loved ones or quarantined loved ones, life-saving strategies and palliative care decisions. Since I expect we won't get to all of that, I encourage everyone on this program tonight to continue to have discussions elsewhere about these topics. I'm anticipating that those who develop this program will develop follow-up programs where things we don't cover tonight can be covered. I also wish to say I believe we'll get through this. My 92-year-old mother says we will, so that's one reason. So we put together this program in the belief that individual actions matter, and because we believe the individuals who are our panelists tonight are on the front lines of those actions, that we ought to listen to see what and hear what they say about how we're making it through, what needs to be done to help us through, what might be done differently the next time. We might also want to hear from the panelists about how we got ourselves into this mess, having seen other viruses around the world that have caused significant death and destruction, knowing what we know, what we might do to avoid letting our guard down while we wait for the next virus to come along. What should we think about? How much are things better than we're thinking, and how much are they worse, or how bad is bad? The panelists are reasons 2 through 8. I think we'll get through this as I believe they are people like them give the reason for the planet to be saved. And I think they'll help save the planet. And with that, I'd like to turn to talk about the epidemiology of COVID-19 and how our physician panelist, who is on the front lines at the West Haven VA Healthcare Center, has seen veterans confronting the COVID-19, and I turn it over to you to say some things about what you're seeing and what your impressions are about the meaning of the numbers.
Louise?
Yes, I'm unmuted now. Start. Okay, so thank you, Michael, and thank you everybody for inviting me. As I said, I'm on the front lines from the perspective of helping keep my facility in the VA healthcare system in Connecticut safe. I do infection prevention, and so this is what we've been planning for and preparing for quite a long time. And certainly, when the real thing comes, it's never quite the way you think it would be. So I just give you a little background. I did work at a SARS hospital in Toronto in 2003, and I remember when I arrived there, basically when I put on my N95 respirator into the hospital I was assigned to, we wore an N95 respirator all day. I felt like my mouth just dropped behind my respirator and said, boy, we have no idea what preparedness looks like in the United States, because they were living it. So it was really an eye-opening experience. Now really living this real time is also eye-opening. I want to kind of echo a little bit what Michael said too about the and I think the sobering thing to just always remind ourselves that behind the statistics, these are people, and they're not just numbers. And it is really, I think, a very difficult time for us also in healthcare, because so much of our focus is on helping patients and doing the best we can by them, and here we balance it also with safety. And so it's a real challenging time for healthcare personnel as well. So I think when we look overall at the epidemiology in the United States, what we're seeing are these hotspots. And even within New England, we have several hotspots. And in Connecticut, where I am at, our first hotspot really was moving up through Fairfield County. And that was a result of the outbreak in New York City and also in New Rochelle. And you can watch the movement of people. And so in looking at the pandemic, it's really a lot about people and where they're moving and how they're interacting and how close they are together. So I don't know if we have time tonight, we can talk a little bit about special populations, and that would be like the prison population, also nursing homes and other areas, homeless shelters, areas where it's really, really difficult for people to separate and do what we call social distancing. So I think, these are the things that get these hotspots to kind of come up periodically. And even in areas where things seem to not be very active, you might see, like in nursing homes, problems. It doesn't take much to introduce a new virus into a nursing home, potentially from a visitor, potentially from one of the healthcare staff, and you have a very vulnerable population. We're all vulnerable because we're almost none of us, unless any of you had COVID-19, but we're not immune. And so we all have risk of getting the infection. The thing is, if we get the infection, some people have a higher risk of going on and having severe disease, and not only having to be hospitalized, potentially be in the ICU, potentially on a ventilator, not survive that experience. And so among the vulnerable populations are the elderly and people with underlying illness. So you can just imagine that's the population in a nursing home, which really sparks outbreaks in nursing homes. And we've certainly here in Connecticut, in a lot of other states as well. And they have occurred in some of the, we call them community living centers or CLCs, like nursing homes attached to our facility. So we're not immune from that. I think, when you look at the models and what they've been predicting, the models are only as good as the assumptions that the models are based on. And they're being modified all the time because this is an ongoing thing. We're learning as we go along. The virus also doesn't necessarily pay attention to the model. What we as humans do can actually modify the model. And I think we've been seeing that with social distancing and the staying at home or sheltering in place, that has had an impact on what was predicted as far as where we would be today with cases of COVID-19. But it does require doing some of the things that we've been doing, and it may mean doing them for quite some time. It's things that's becoming apparent. I think you've all heard this on the news, read it in the paper, that until we have a vaccine, the virus is going to continue to circulate. The goal right now is to try to get it down to a lower level and try to keep the circulation of the virus low, and not have as much transmission or opportunities for transmission. And be able to be at a level that healthcare facilities can manage the number of patients who need their care. So that's going to be, I think, an ongoing challenge, as nobody thinks we're going to have a vaccine for at least a year. And I can't imagine this virus is suddenly going to disappear from the whole world without something like that. And at some point, we do go back somewhat to our lives, going back to work, starting to travel a little bit more, and there will then be transmission of this virus. There's just no way around it. And I think that those are things we have to remain cognizant of, and start learning to feel, I don't want to say comfortable isn't maybe the word, but aware that there are going to continue to be cases and there are going to continue to be deaths, and we all have to do what we can to prevent them. Now, in the healthcare system, and talk about the hospital, I think the challenge with this is people start to sort of burn out. We want to see the cases go away. We know in Connecticut, our peak is predicted. It depends where you are in Connecticut, but overall for the state, I think sometime next week. And in some places, the state, it's already peaked. In some places, it's still going up. And I think there's a sense of we hope that, you know, after the peak, the cases will come down and they'll disappear, but we're going to have to remain vigilant. And I think that'll be the challenge, because right now, every patient that comes in, we think, could they be a patient, a COVID-19 patient? And as we get back to a little bit more business as usual, we start to do more elective surgery. We start to see the patients that we normally see coming in who now are staying home. You know, we may drop our guard a little bit and not think of every person and saying, could they be a COVID-19 patient? And we may start seeing more transmission in hospitals. That's a concern certainly that I have, as well as I think we're going to talk a little bit later about some mental health issues. This is really a stress on healthcare personnel. And as humans, I mean, it's always difficult dealing with the unknown. And we need to remember we've only known of this virus for about 4 months, maybe 5 months. And so there's still a lot to be learned about it and a lot that we don't know. And that becomes challenging. We're in the middle of dealing with this because everybody wants the perfect answer. And I think they'll tie that in also then with testing and thinking that, you know, we want the perfect test, the test that's 100% accurate 100% of the time. And that doesn't exist. So as much as we have challenges with access to testing, there are imperfections with testing as well. And hopefully that will get better over time, become more precise, will be easier to administer, quicker to get a result, and that will certainly help. But we are far from being there at this point in time. I think maybe I was asked also to address a little bit about the experience for the veteran population. And I think the challenge of the veteran population, as many of you can imagine, we have a pretty large proportion of our patients who are elderly and have comorbid conditions. They live in nursing homes or they live at home with home health care. So for them, it's a challenging time. They don't come for primary care visits. We do a lot of telemedicine. I think for some of our patients, actually, the VA, when they come to the VA, it's a place where they come and they socialize, and now they've been cut off from that. So there's a fair amount of loneliness involved, as well as not being able to connect the way they usually do with their providers. We try to explain to them why this is for their safety. We want them to remain at home as much as possible and not only come to the VA, but also limit their exposure in the community. I think what's interesting when I look at the numbers, though, particularly for VA Connecticut, we serve all of Connecticut and some parts also of southern Massachusetts. It really is a mirror of the community overall. So if I were to say, for example, Yale New Haven Hospital, where I practiced for many years too, it serves the community around it and also captures some other patients from around the state. But for the most part, for something like COVID-19, it serves the local community. But we at VA Connecticut, we get our patients from Connecticut. And so we're seeing some differences there as the virus is really moving through the state. And I think it's an interesting way to sort of look overall the population of the state that other healthcare facilities in Connecticut don't get to have a view of.
Louise,
I'll stop there.
Louise,
Yeah.
from the standpoint of an epidemiologist looking at the picture, is there a difference between, or how much of a difference is there between trying to corral the in, say, Chester, New York, from to corral the virus that's worldwide?
I'm sorry, Michael, you were breaking up. Something about the virus in New York and worldwide?
Let me try it again. How much of a difference is there the response to the virus when you're trying to corral it within a small geographic area as opposed to worldwide. Same strategies?
Yeah, so I mean, the strategy is the same, but implementing them has different challenges in different places. So, you know, even if I Connecticut as a microcosm, if I were to look at inner city New Haven, the challenges there are very different than they are in some more rural parts of Connecticut. So in inner city New Haven or downtown New Haven, as you're well aware, there's a fair amount of poverty, there's a homeless population. When we ask people to socially distance even in the home, to stay 6 feet away from each other when they're living, you know, 5 people in one room, that's an impossibility. It's very different than when you're living in a home, a bigger house in rural Connecticut, and everybody has their own room. And so I think there's some similarities a little bit when you look at New York City, where people are living in large buildings, many apartments, small apartments, many people living together. So doing social distancing, which I believe is really a very basic practice as we have to do and we're going to have to continue to do. It's much more challenging to implement. So I think, you know, it is a practice we have to do. We have to figure out how to do it better and how to be able to do it in populations where it's not something naturally that they can do.
Thank you, Louise. Robin, can I ask you to address how you're experiencing COVID-19 in Maine?
Sure. So my name is Robin Noble. I'm a gynecologist in Portland, Maine, in a physician-owned multi-specialty group. So reporting from Maine, and I will be filling in also for Dr. Valenti, who's our epidemiologist. He's really my go-to ID guru, and he couldn't be with us tonight. And I have to say, from an ID doctor's perspective, to take a family member to the ER with a febrile illness has got to bring this all home to us. So my heart goes out to him, and I will report from Maine for both of us. So what makes Maine different from these other areas of New England is really that Maine actually has the oldest population in the United States. The median age in Maine is 45, and 20% of our population is over the age of 65. In addition, we actually have one of the oldest physician workforces in the country. I think we are the 5th oldest physician workforce in the country. So that really could have been a setup for a COVID disaster. You know, fortunately, I think we're in a relatively good position. Mike, you went over some of the numbers, and, you know, our numbers have been much better. You know, currently, I'm not going to go through the numbers, but, you know, doubling time is something that epidemiologists also talk about. We were recently at something like a 10, 11 day doubling time, which is, you know, somewhat reassuring. Now, why this happened, I think there are a number of factors. Some people have touched on, you know, geography and populations, as well as, you know, some of these earlier maneuvers. I saw on the sidebar someone from Washington about social distancing and about some of these maneuvers can be tremendously important. So although we were one of the latest for a stay-at-home, Governor Mills, you know, didn't issue the stay-at-home order until officially April 1st. She actually declared a state of emergency on the 15th of March. On the 18th of March, there were restrictions on social gatherings, no gatherings over 10 people. On the 25th, there were, you know, closures of non-essential businesses. And in fact, many other people in the area kind of followed suit and were very proactive. So in my organization, we actually made the decision to close our ambulatory surgery center as early as March 16th, which was actually even ahead of the major medical center. And those decisions to kind of, you know, restrict elective procedures and conserve personal protective equipments and try to prepare. That helped us a lot. And I think because of that, we're in a slightly better position. You know, I'll talk about some other issues that some people have brought up too in terms of kind of burnout and the other broader economic aspects. But we were also in a good position because Dr. Valenti, who's the Maine Medical Center epidemiologist, had done some disaster planning for Ebola back in 2014. And so we were already in a slightly better position, but even with that, there was a lot of chaos in mid to late March in terms of these, moving targets for recommendations. So whether people should be masked, whether providers should be masked. For example, I'm a gynecologist, I no longer do obstetrics, but my partners, were not masked with laboring patients. There was very inadequate testing. The delays were just abhorrent. We would send testing and some of our results would take 7 to 10 days out of the CDC in Atlanta. So there was just not adequate access to testing, inadequate turnaround, and, moving targets in terms of what people should be doing, even with the best intentions. So I think that added to a lot of the stress. As I said, I come from a multi-specialty organization, and it just required us to be very nimble. So we made decisions to close these non-essential aspects like the ambulatory surgery center. We closed our physical therapy department. We consolidated services at a sick site and a well site. We literally built tents for outdoor testing, in a matter of days to do COVID testing. But again, then we ran into supply issues and turnaround issues. And this was all in the face of, steep declines in revenue. I mean, these practices and these communities, healthcare centers alike, have looked at 50 to 75% reductions in revenue, which in turn require, cutting staff, the very personal decisions to make furloughs, particularly in a physician-owned group, to offload staff and really multitask in order to stay afloat. So many of us were kind of learning new things, trying to adapt and adjust in the face of this financial reality, as well as the fear and the stress of these other moving targets. So, Stephen Bird had talked about telehealth. In some fields like psychiatry and mental health and addiction health, telemedicine has been used quite readily. And for rural areas, for a field like gynecology, it's virtually unheard of. And I was up and running in telehealth, within a week. However, there are limited things that I can do with telehealth, but our whole organization rolled this out to all of our departments. And we really made a lot of changes as quickly as we could. Now, given all of these maneuvers were necessary for safety, this flattening of the curve that everybody has heard about so that we wouldn't outstrip our PPEs and our hospital beds and our workforce and our ventilators, it came at an enormous cost, not only a cost of revenue, but really an access to care. So I think what people don't realize is it's access to care for everyday care and preventative care. And what happens is, your routine screening mammography and colonoscopy and all these procedures get easily pushed out at least 3 months. And then it can become 6 or 12 months when you look at the broader economic impacts of COVID and job loss and loss of insurance. And all of a sudden you add to, the death toll really with delays in diagnosis, and the real fatalities related to COVID are much larger than we can even tally, let alone the problems with testing and even the problems when we look at death certificates and how they count these deaths in rural areas. So I think people often don't realize the broader aspects of access to care and preventative care that really gets put off, and we won't see. And we saw some of this in 2008 in recessions where people then don't come for medical care. So there are other things that we're all thinking about, and how we, keep things running, keep our lights on and our doors open to take care of our patients. But then, what's also been touched on a little bit is this concern for burnout. There's more awareness that burnout is a problem, specifically for physicians among professionals. It's an area of interest for me. I serve on our kind of peer-to-peer counseling at Mayo Medical Center for kind of bad outcomes and working with your colleagues in how to deal with these stressors. But COVID has just exacerbated this enormously, because not only do you have now longer hours and you have physical stress and emotional stress, uncertainty, but now you've got financial worries, and it just compounds all of these issues. So I really worry about our workforce as well.
What about labor and delivery? You've closed ambulatory surgery centers because elective procedures are not. Labor and delivery isn't elective. Where is that happening? How is it being handled in the context of very sick people in the hospitals?
Yeah, I mean, it's a great example because as we all know, the babies keep coming and there's nothing you can, you can do to stop that. It's certainly not elective, but it brings in, managing our populations locally safely. But we also have people, fleeing areas like New York and Boston and coming for new obstetricians. And we've certainly seen that, not in the numbers that we expected yet, but we certainly see some of that. So there's no way to stop it, but it's been a moving target. My partners were extremely concerned initially when people weren't masked and we had inadequate testing. It has gone from totally unmasked to what we call PAPR or PAPR. These powered air purifying respirators that almost look like a laminar flow. Those are used now for C-section. One of the hot topics, and I know we have a neonatologist coming on, is the contradictory recommendations between the American Academy of Pediatrics, the CDC, and the WHO in terms of separating a positive mother from her infant. I mean, this is unheard of. It's never been recommended to separate a mother from her infant for 2 weeks. And this is what some people are recommending. And breastfeeding, does not transmit COVID as far as we know. But as Louise mentioned, we're learning about this on a daily basis. Many of us feel like we're students again. I've read more articles in the last 6 weeks than I probably have in more than I care to say. But to separate a mother from her infant has mental health implications for postpartum depression as well. Now they're recommending that perhaps they can breastfeed them and be masked. But this is, we're dealing with this day to day. What's the best thing to do?
Thank you. Let's move over a state. Lars, you are in one of the centers of COVID hotspots. I think you're still considered that way. Is that the case?
Yeah, I mean, I think, I follow the numbers like everybody else. I think Massachusetts is number 3 in the US after New York and New Jersey. I'm sure the epidemiologist on the line can comment. And I'm speaking tonight as an orthopedic surgeon. Obviously, like all of us, I wear lots of other hats. It's amazing. I was on vacation up in northern Vermont. I operated on Wednesday. I came back on Monday morning, and our sports medicine floor had been converted into a COVID clinic. So it's really amazing. What I do, I'm at Mass General Hospital, a giant academic, internationally prominent medical center in this sort of micro specialty. And from a personal standpoint, no one's allowed to play sports. All the students from Hartford have been discharged. The Bruins are no longer playing. No one's out playing basketball. Our offices are a COVID ward and the ambulatory care center is closed. So, it's like driving a Ferrari into a brick wall and we're just stopped doing nothing. So as a sports medicine specialist, it's unbelievably disruptive. And anyone like me who's not a pulmonary care ecologist or an internist has seen a complete stoppage of workflow for all intents and purposes. Like Robin, I spent a week learning about things like Zoom and Doximity and virtual visits. I've learned more about personal computers in the last week than I have in the last 20 years. I'm practically writing code here in my garret up here in Jamaica Plain. But yeah, for me, it's very disruptive. And so I feel very fortunate. One, I think without making any comments about national politics, I think our state has done a very good job at the government level about being very aggressive and proactive. I work at Mass General Hospital. I think the technical term is it's very well resourced. We have never had any shortages of PPE. They have an almost military approach to things. You go into the hospital, you're met at the door by a whole squad of security. You have to log on and be attested that you have no symptoms of COVID. You get a mask and you can't take the mask off until you leave the hospital. The way we do surgery now, there's a whole different protocol. The patient's intubated. No one can go in the room for half an hour where they let all the droplets disperse. You go in and do the surgery. Everyone leaves the room. They extubate. You take the patient out and no one can go back in the room for another hour. So you can imagine the throughput has ground to a halt. If you look at a hospital perspective, 20% of Partners revenue comes from the Department of Orthopedics. So you can imagine just trying to keep the ocean liners sailing forward, taking all the coal out. It's a struggle. A lot of us, you know, it's hard as a physician, being extremely highly trained and really dedicating your whole life to patient care. Suddenly you're in a spot where really I can't do anything. I volunteered to take some types of call that I don't normally do. I'm taking care of some underserved populations from an orthopedic standpoint. I'm doing virtual visits, but most of us are really stuck. We eventually, about half of us volunteered to do some respiratory clinics. Those haven't been busy us. What MGH has now done, which I think a whole bunch of us are going to volunteer for, is they've set up a field hospital. And with the National Guard, they've set up something like a 1,000-bed hospital, which is going to house people that don't need to be hospitalized and also serve some of these populations that are hard to socially distance. So it's a way of treating people in a non-hospital setting and also implementing some public health measures in populations that are hard to affect social distancing. They're also, yeah.
So being in the academic medical center, have you heard much talk about how or what this means insofar as the future training of doctors and what's being said?
Well, I would say most of the stress is more short term. So if you look at a resident or a fellow, starting with the fellows first, a lot of them have their jobs rescinded. You know, they're trying to join private practices and those have all evaporated. So now you have a whole bunch of people who've been training for 10 years to be a specialist and suddenly their job's gone. If you look at the resident level, there are all these sort of core competencies. So you have to do X number of operations, you have to develop Y proficiency, and how are you going to get that volume in a slotted time form if we're shut down for 3 to 6 months. So the short-term part of it, I think, is very stressful. I do think one of the things that's been a big challenge in academic medical centers, especially big ones, is a lot of us operate in multiple different places and are maybe one place on Monday, the next two Tuesday, then a third one Wednesday, a fourth one Thursday. So doing things like conferences and group education has been very challenging. And I think embracing technologies like Zoom is really going to enable us to reach a wider audience, not only internally, but externally. And I think it'll help with dissemination of information from academic medical centers, both within a giant department that's spread over 4 or 5 hospitals, but also nationally and internationally. So I think the embrace, you know, a lot of us surgeons are Luddites at heart. And so for us to be forced to embrace new technology, I think is going to be transformative. Is that too long-winded?
No, and it really tells a lot about the dislocation that is involved in COVID-19, almost shattering of the healthcare system as we know it. But I'd like to move on from your specialty to the mental health, behavioral health, and ask Pat Rehmer to join and say what from your perspective, Pat, as a former commissioner of mental health and addiction services in Connecticut, and now in a senior level position in a healthcare system in Hartford, what are you seeing and observing and thinking about in the context of how COVID-19 is being addressed in the behavioral health area?
Thank you, Michael. I think that, like everyone else, it's a short-term, long-term game. And in the short term, we're certainly worried with us asking people to isolate and distance themselves about that isolation and the impact that could have on people's mental health. Obviously, people that are prone to depression or anxiety, it's not really good for them to be isolating. On the other hand, I think the other thing that we are seeing in Connecticut is an increase in domestic violence. And so I think that on the one hand, people are isolated. On the other hand, they're feeling suffocated. You've got 5 people living in the middle of Hartford in an apartment, and 2 of the kids have to be homeschooled or distance learning. You know, when you really are creating a lot of tension in a house where that situation can pretty quickly get out of control. So it's really a balance. You know, this is in many ways, in my mind, and perhaps it's the way I think, but this will become a behavioral health disorder crisis. We're just going to build into that, I think. What we're seeing now in Connecticut, and I have not seen this before in 35 years, is people are not coming into the emergency rooms for psychiatric care. We have transformed our system in about 3 weeks to almost completely telepsychiatry for outpatients and intensive outpatient programs. And in Connecticut, by the way, there was no telepsychiatry prior to this because nobody was paying for it. So us being able to move to that platform in 3 weeks has been amazing. One of the things we've seen is that it increases many individuals' participation in treatment. Our no-show rate is actually going down. So I think that's really important, but I also think that there's so many things that people said that I'd like to comment on. I mean, the whole issue of the idea of separating mothers from their babies, the impact on not only postpartum depression, but the really long-term potential impact on an attachment disorder between the mother and child is certainly concerning. And clearly we are going to see PTSD. Our healthcare workers are struggling. At Hartford Healthcare, we've brought up a hotline for our healthcare professionals. It's staffed by our behavioral health staff. And we're very concerned about how people are reacting to this. And again, in Connecticut, we are, as somebody said earlier, seeing sort of a wave. So we're seeing down at St. Vincent's, for example, obviously highest volume and the most difficulty among the staff. And I think maybe the only good news for Connecticut is that we do seem to be rolling across the state. And so while Fairfield is suffering, Wyndham is not. So at least in our system, we've been able to share things like ventilators and ICU beds, which has certainly helped. And I think helped the staff feel less anxious. They know that there might be at least a bit of a valve for this to release. I think in the psychiatric portions of our system, it's very dangerous. We are very concerned on an inpatient psychiatric unit or in a residential program that if somebody becomes infected, it could infect potentially the whole unit because of the way units function. We have opened a small COVID unit for psychiatric patients. We have not seen that filled to capacity yet, but again, we are still preparing for the surge. I will say the telehealth situation for us, if Connecticut decides to continue to pay for it, it really will increase access for us. As much as there are some patients that are not able to use this and we're always going to have face-to-face time, there are a lot of, especially young adults, that are very interested in this and that we are reaching much more consistently. So we believe that when this comes to an end, there will be a need for behavioral health care, but we will be able to provide more access.
Thank you, Pat. Mark Mercurio, you are both a neonatologist and neonatal and perinatal medicine, but you're also an ethics expert. As you are sitting in the midst of all of this, do you have some general observations about the ethical questions that are being posed throughout the country and throughout the world? Do you have other observations relating to access to care and that sort of thing?
Sure. Thanks for the invitation to speak to you folks. I direct the program for biomedical ethics at the medical school. And in that role, I was asked to participate at Yale New Haven Health Systems, Yale New Haven Hospital and all the health systems in development of the triage protocol. And this has pretty much occupied all my waking hours for the past 4 weeks. I've been working with 11 other people, drafting a triage protocol for critical care resources. And you've heard about some of this on the news. And this has been primarily what my concern has been, is that ethics work. So there are 12 of us who drafted this protocol and over 60 of us that reviewed it, and many, many, many drafts and constant email traffic back and forth. reaching out to experts all over the country with our suggestions for them, their suggestions for us, and building on other things that were in place. Because ultimately, the question became, and the question that I focused on most in the past 4 weeks, has been what happens if we don't have enough critical care resources? And ventilators are certainly ventilators are a proxy for all that. And that's of course the main easy to get your mind around idea of that if we don't have enough of those, what's going to happen is some people are going to get one and some people are not. These are people who need it to stay alive. And so what has to be done is to create a triage protocol determining who's going to get the ventilator or whatever other critical resources that we're talking about. And the creation of protocols like this is extremely difficult. Some states had developed guidelines before this crisis. Connecticut, where I work, is not among them. And even those that did have guidelines have quickly gone through and updated them or changed them. But we moved very quickly from a medical ethics point of view to a very specific goal, a utilitarian goal, which is simply we want to allocate these resources in such a way that's going to save the most lives. And this is difficult from the other ethical principles that we've called into our practice on a daily basis. And we want to save the most lives is the goal. And you want to do it in a way that's fair, in a way that's feasible, and you want to do it in a transparent fashion as well. And so creating something like this has been extremely difficult, but ultimately it's necessary. So you create a document, a protocol that's not perfect, but you really endeavor to make it fair, to determine what are our criteria for who gets them. And essentially what the criteria, first of all, you determine what the criteria aren't going to be. And there are things that you would hopefully assume, specifically things like ethnicity or race or ability to pay or a putative VIP status, immigration status, things like this, disability status. Things like this are not figured into the protocol. Really, it's trying to predict who's more likely to survive with the ventilator or with the other critical care resource. So calling together different formulas based on physiologic criteria, on laboratory values, and on certain comorbid conditions. And with that, coming up with a prediction in our system, and I think many of the systems you read about, basically, ultimately, patients are given a number from 1 to 8, a lower number being better. They're assigned a protocol, a triage protocol score, and then the resources allocated based upon that score. We have not had to invoke this protocol yet. We have finished it, it's written, it's been approved by the hospital, and our strongest hope is that it never has to be called into play. And at the moment, the people who run our organization have done a very good job. We've got enough supplies, we have enough critical resources, we have enough ventilators. A lot of places, I mean, you heard about it from Lars, a lot of places that used to be other things are now intensive care units, medical intensive care units. The hospital is a very different place than it was. But thus far, we have not run out of those critical resources. We've created this policy in an attempt to be fair in how we do it. And that's essentially the parachute that we hope never to have to use. Some of the specific questions that get argued on a local and national level, the one that interests me most, a lot of them interest me, but one of the ones that's very interesting is should age factor into this? And one would say that, well, if we had two people who had roughly the same chance of survival, if they get it, would we want to give, and we had a choice between a 70-year-old and a 20-year-old, should we give preference to that 20-year-old or to a 10-year-old child? Because one thing that's important to recognize about these allocation protocols is it's not just about COVID-19. As I think everybody in the call probably knows, small children, it's very unusual for them to get sick from COVID-19. But the triage protocols are for everyone in the hospital. So if there's somebody in the hospital who needs a ventilator because they have a terrible pneumonia from COVID-19, and there's somebody else in the hospital who needs a ventilator because they're a premature baby with respiratory distress syndrome just by virtue of the prematurity, they're all in the pool together. All the patients are in there together. And the main criterion is going to be predicted survival if they get the ventilator. But how? Go ahead, please.
How much have the questions you've confronted changed from the things you've probably been thinking about for the full time you've been involved in facing ethical questions? Is this just more of a reality than the questions you've discussed over time, more maybe hypothetically?
Well, no, I mean, I would say that the bioethics work that I do is very real. It's not hypothetical. I'm a medical ethicist, and I do a lot of work related to ethical issues in pediatric care. I do a lot of work related to end of life ethical issues. So we deal with life and death issues. We deal with them one patient at a time, and we focus very hard trying to understand the desires of the family, the desires of the patient. But now we're in a different sort of situation where we have two patients and two families, and they all very much want that one resource. And so we have to switch. It's been a real switch to a more utilitarian calculus, but one wants to temper that utilitarianism with a sense of justice and fairness as well. So it's been, for me, a completely new experience. And I think perhaps for those who have studied public health ethics, it's not so new, but it's an awful lot more real.
Let me try one thing before we run through all the time that we have. We had about 180 registrants from about 18 different states. I think we should at least give a go to taking some questions from our registrants. If that gets a little clunky, maybe we'll return to just some last comments from panelists or additional questions to the panelists. Rachel,
Michael, I actually pulled out the questions. I'm happy to read them out, if that would help.
That would be.
Okay, so these are no order of, I think, received. So everyone can hear me, I hope. I'll unmute everyone. When somebody asked if the panelists were in charge of determining the criteria for opening the country, what would be the criteria, if you can do this without being political, maybe from just a physician's or medical healthcare provider standpoint? Anybody want to take that?
I can give it just an initial stab, and then someone else can say something more intelligent. I mean, my biggest fear in this whole thing, aside from losing someone I love, which is everyone's biggest fear, my biggest fear in this whole thing is that we're going to reach a point where we don't have enough ventilators or ICU space to take care of the patients. So from my standpoint, the longer it goes with the severe restrictions, the better. I mean, in terms of saving the most lives, keeping us to below that level where the system is simply overwhelmed is preferable. I also recognize that I'm going to get a paycheck throughout this whole crisis. There's an awful lot of people who won't. And so for an awful lot of people, there's a tremendous financial crisis, which could eventually have tremendous negative impact on people's lives, potentially cost lives. So someone smarter than me is going to have to balance those two. But recognize, simply from a physician's point of view, the longer we do this, the better, until it's clearly way, way down. The economic incentives are important. Hopefully there's going to be ways to ameliorate the economic damage so that we can do this as long as possible. But obviously, we don't want to make the transition so soon that if we're lucky enough to dodge this bullet of we didn't overwhelm the healthcare system in April, fantastic, and then we make this transition too soon, then we find ourselves in mid-May or late May overwhelmed at that point. That's going to be disastrous. And we're going to also recognize that that wasn't really necessary, because we did figure out a way to at least slow that tide.
Did you unmute me, Rachel, I think? Can anybody hear me? It's Robin.
Yes, Robin.
Okay, so I would probably defer to Louise, given that she's an ID specialist and epidemiologist, but I would certainly favor that we need adequate and expedient testing for sure, and adequate contract tracing. So in a place like Maine, where we haven't even tested half the people under investigation, we're not at a point where we could adequately test people and do contact tracing like they have in South Korea. So I would say that's what we need, and we don't have it yet.
Yeah, so this is Louise. Can you hear me?
Yes.
Sorry, I know there's a little bit of delay. So I would echo what Robin just said, is we need to continue doing the practices we're doing now on sort of a what we call like a new normal way, maybe not as draconian.
I think we lost you, Louise. But let's-
Okay, I think I'm back. So,
Okay.
I'm having a lot of trouble. Sorry about my technical difficulties on my end. But I think we also need to be setting up a system, and I know that departments of public health are really working on this, and it's really challenging to do, as what Robin just said, is with contact tracing. Right now, we're really not even doing it so much out in the community. It's just not worth doing. And with that, you have to tie that in. You have to be able to also do testing as well as tracing people. And then there has to be an ability for people to stay home until they're considered non-infectious. But when you do contact tracing, there are many, many layers to that. It's the individuals that can remember they were in contact with, and those individuals who they may have been in contact with. And then the big challenge in a lot of this is, and we haven't talked about it tonight, but we don't know enough yet about asymptomatic transmission. We talk about it, we believe that it plays a role, but how big of a role does it play? If it plays a very large role in transmission, we're going to have to do something that's a little bit more test-based than symptom-based, and that means widespread testing. And then the question is, how often do you test? You test one day and somebody is negative. That doesn't mean they're negative the next week. So there's still, I think, a lot we got to do, and that's why as we open up, we start talking about this, it's got to do it slowly, got to watch the numbers. If we start to see things go up, we've got to pull back. We've got to think about what we can do. But I think certainly starting with areas that can continue doing social distancing, thinking about new ways to do businesses that allow that is where we're going to have to go, because we're going to be in this for the long run.
Louise, could you please address the issue of seasonality? Lots of people feel like over the summer this is going to recede a bit. And yet you look at places like Singapore and South Korea, which are also hot, that had a resurgence. What's your perspective?
Yeah, I mean, nobody knows. I mean, some coronaviruses tend to have more of a seasonal circulation, like the ones that cause the common cold. And then there's others, if you kind of look back at the epidemiology of SARS, there were cases all the way into July. And then another coronavirus, which is MERS, the Middle East Respiratory Syndrome, you see much more in Saudi Arabia, in the desert, and in some hot areas. So I don't think we know enough about this virus. Will the warm, humid weather make it less likely to transmit, which is true of a fair number of viruses, or will it not be impacted by that? So I think time will tell. We're going to have to stay vigilant. We're going to have to watch the numbers. We're going to have to do testing and see what happens. I think, there is sometimes a little bit more social distancing in the summer because people are outdoors more and less indoors, so that may also help. But I think, we all expect we're going to see cases through the summer. This is not going to stop transmitting. Hopefully at a lower level because of what we're doing now and maybe because of the weather, but we'll have to wait and see.
So we have about 5 minutes. Each of the, if you'd like, each of the panelists, if you'd like, could you say what you tell people when you're trying to be hopeful? Louise?
Okay, let's start. So I think it would remind people that as much as the numbers seem daunting, the vast majority of people who get this infection do fine. And I think it's time we have to focus on the positive parts of the numbers, and we each need to do what we need to do to keep ourselves safe, keep our loved ones safe, keep our colleagues safe.
Robin?
I think I'm in a better position being in Maine because our numbers are much lower. That, as Louise said, I think that the reality of infection, is the risk is going to be very low up here. So a lot of what we're dealing with are issues related to anxiety and isolation. So, I probably recommend kind of more exercise and outdoors and mental health through their pets if I can, and realizing that this too will end and we will get through this.
Thank you, Robin. Lars?
Oh.
Did I mute myself? My ex-wife, who's a Yale physician, describes me as pathologically optimistic. So, you know, I'm generally a positive person. And I think, you know, you think in your own life, my mom grew up in occupied Europe with Nazis marching past the front door. Humans have been through very, very bad times, and humans are resilient, and we'll get through this. And I'm very positive, and you try to be positive. I think as a physician, half the battle is trying to convince patients they're going to get better, they're going to feel better, the placebo effect. And I think this is innate to those of us that practice clinical medicine. We're going to be okay.
Patricia.
Patricia.
Oh, sorry.
Okay. Go ahead, Patricia.
I think I agree completely with Lars. The most important thing right now for us is telling people that we will get through this, certainly our staff as well as our patients, and really the support is going to be the incredibly important thing in the next year, I think.
Mark?
Well, I think that everyone said it very well in terms of a sense of optimism, and the kind of work that I've been doing in over the past month is the worst case scenario. So I've been so focused on the worst case scenario. It doesn't hurt for people to be aware that we are preparing for the worst case scenario, because I think to some extent that helps keep us sober and on task for avoiding the worst case scenario, because it looks like with a little bit of luck and continued hard work, we'll be able to avoid it. And a lot of people have worked very hard. So I do think there's an end to this. And thanks to the hard work of a lot of people, we're going to avoid the worst case scenario. But I do think people need to be aware that if we don't handle this properly, things can get a lot worse.
Thank you. Thank you to every one of you that we were able to get you to join us tonight when I can only imagine the hours of sleep you've missed over the last month and longer. It's very appreciated. Joellyn, did you have, I got to give you credit for pulling this all off. And I asked you to close this out.
Well, I'd love to. There were two additional questions that came up, and I don't know if a few people could stay to actually answer those. One is actually related to the disproportionate negative outcomes of COVID-19 experienced by African American and Latino populations. And specifically, the question is, would uniform use of race, ethnicity, and language data assist with the analysis, identification, and elimination of these disparities?
So this is Louise. I'll take a stab at it. I will tell you right up front, I don't know anything about REL. But the thought right now is about the disproportionate negative outcomes experienced by African Americans and the Latinx population may have something to do with their higher rates of some of the comorbid conditions that have been associated with worse outcomes with COVID-19. Diabetes being one of those, but also cardiac and pulmonary disease, as well as obesity or a higher BMI. So we don't know yet enough, but that is the current thought that may be the reason why they're experiencing worse outcomes.
That's great, thank you. And there's one final question that maybe Mark and Lars can take, because it's regarding overall medical education and the impact. And it's really around how will medical education change for future students as a result of this experience with COVID-19?
Mark, you want me to say something?
Sure.
I alluded to this before. This is slightly off topic. I've argued for a long time that higher education is ripe for disruption. You know, when it costs $75,000 a year to go to Yale, it's ultimately going to get to a point that's not sustainable. You know, when 1%ers like us are stressed about paying for college, it's a problem. And so I think what's going to happen is that we're going to be actually better able to educate people, and certainly at a local level at Mass General, these Zoom conferences have been fantastic. So what we've done just on the ground is, so the residents are, taking shifts at home to make sure they don't get sick. So we rotate, and every morning someone gives two different surgeons give 2-hour lectures, and so we have didactic stuff every day. And it makes it much more facile to disseminate information and give lectures, have the people that are best served to teach this stuff and are most effective and reach the broadest possible audience. And if you think at a place like, let's say at Yale, you have the best calculus teacher on the planet. Well, he could teach every freshman in the United States on YouTube. And so I think there's going to be giant disruptions from all of this.
So this is interesting. Michael began, when we first talked about doing this event, Michael said, I really want to focus on the lessons that are being learned. And I think we heard some really good ones today. We learned about the whole triage protocol that's being established at Yale New Haven, which sounds, while a little bit scary in terms of what the needs for it are, it feels more fair and just because there is a protocol that's really outlined. We've heard Pat talk about the need to really, and the benefits that are coming from telehealth in terms of its access to patients who have psychiatric and anxiety issues. We heard Lars talk about the ability to disseminate more information more quickly with students going forward. And also, I'm sensing across all of you an incredible collegiality and all wanting to work together to solve this. And Louise, it's amazing to me the amount of information that you have that you've been able to share so quickly about the epidemiologists of this disease and how people are really watching it and monitoring it, and the candor with which your profession is saying we don't know, but here's the best that we can do. I want to thank all of you. You all have an incredibly important perspective. We so appreciate what you're doing, and I wish there was some way that we could give you more accolades than simply by saying thank you, but we're saying it from really the bottom of our hearts. Thank you very much for your time tonight.
Thank you, everyone, for joining us.
Thank you.
Thank you to participants who patched into the program. We hope it was beneficial to you as well.
Thank
Have
you.
a great night.